morning. Good morning. On behalf of the Knoxville Chamber and the Tennessee Small Business Development Center, I'd like to welcome you. My name is Bruce Hayes. I'm a senior consultant for the Small Business Development Center. And in cooperation with the Knoxville Chamber, we put on the right ideas. We think it's a nice collaborative effort to bring educational opportunities to business owners so they know what is ready to come at them, whether it's the light at the end of the tunnel or the train at the end of the track that's coming at you. So, again, welcome. We have a great presentation this morning from Jeannie Campbell Hitchcock and on healthcare reform. So, Jeannie is a business coach for Astrana Strategies. She holds a bachelor's degree in organizational behavior from Rollins College in Winter Park, Florida. In her 25-plus year career, she has served as an executive leader, an administrator, consultant, a business owner, and an advisor. Her past role as COO of Summit Medical Group, and as a partner with Kirsten Yoakley, she's gained a different perspective, an employer's perspective on healthcare and healthcare reform. Would you give a warm welcome to Jeannie Campbell Hitchcock? Thank you.
Okay, I hope I don't need the mic. Can everybody hear me? Good, good, good. If that changes, just raise your hand and I'll work on using the mic. As my introducer said, I have the perspective that I bring to you today as not only someone who's negotiated benefits and worked on benefit plan design with insurance brokers, but also someone who's had a 25-year career in healthcare working for hospitals and physician organizations. And so I hope what I can bring you today is a little bit different view about healthcare reform from the perspective now of a business coach. And as business coaches, what we talk about all the time is that there are many areas where business owners and executives really don't know what they don't know, right? I mean, why do most small businesses fail within the first 5 years? Anybody know? Usually what you hear is cash. I think cash is a symptom, not the cause. The cause is really if you haven't planned for enough cash, you didn't know what you didn't know, right? And so you failed. And so the objective here today is to give you enough 5,000-foot information about what's going on in the healthcare reform arena, how it might affect your employee and your workforce engagement issues, and then some insider's information about what's going on in healthcare that can help you to purchase the best healthcare if that's what you're deciding to do with your company. I'm not going to try to solve your individual situation. A broker came up to me, he's in the audience today, and said earlier this week they gave a 7-hour workshop on this. And you really can give a 7-hour workshop on this as you try to delve down into each individual situation and nuance. And so everything I'm going to talk about hopefully will give you a starting point to do an analysis on your individual situation. So we're going to take this in 3 sections. The first talking a little bit about the healthcare reform law, and then I'll stop for questions on that. The second will be about workforce engagement, and we'll stop for questions after that. And then lastly will be the healthcare industry, but we'll stop for questions, and then we'll do a little, I can get out my own crystal ball, which I have to do a disclaimer that it really is Jenny's crystal ball. It's not Astrana Strategies' crystal ball or anybody else's crystal ball. It's just what I think could likely happen from my experience. So let's keep it high level and help you get a sense of what you may not know and what you need to learn more about. So I moved to Knoxville in 1996, and like many Knoxvillians, I came here for a job. I came here to work for what was then St. Mary's Hospital. I actually interviewed Sister Elizabeth. I don't know if any of you ever knew Sister Elizabeth, but a lot of things have changed with St. Mary's. But I came here to play an administrative role in their physician organization. And I left a company in Tulsa, Oklahoma, the station of a company in Tulsa, Oklahoma called HCA. Anybody heard of HCA, Columbia HCA? Yeah. Huge company, 250,000 employees. Really was in a lot of trouble in 96 when I came. There was a big compliance scandal, and I just decided, I can't work here anymore. This is not a place for me. So I got on the job market. I found Knoxville. There were people here that I knew, just a few, and I thought, well, I'll go live there for a few years. That looks like a great place to live. It's a fantastic career opportunity. I'll just be passing through. And like so many people I talk to who live in Knoxville and make Knoxville their home, I fell in love with the area. Knoxville is beautiful. So much natural beauty here, such as southern warmth, proximity to so many great metropolitan areas, and have great culture, and it's only gotten better and better and better over the 18 years that I've lived here, and I hope to live here forever. But one thing that was nice about living in Tulsa is that I lived close to my parents. And my parents lived north of Little Rock on Greers Ferry Lake. Anybody ever been up around Greers Ferry Lake in the Buffalo River? Beautiful, beautiful area, just as beautiful as Knoxville. And lots of folks come from all around the area to go to the lake and on the Buffalo River on the weekends. It's about a 3.5 to 4 hour drive from Tulsa to Greers Ferry Lake, depending on how you drive. And so what you can do is you can go to Little Rock and you're on 40 and in essence make a left and drive up north of Little Rock, go to the lake. Or there's a cut across road. And so before Little Rock, you can kind of make a diagonal cut across right to Greers Ferry Lake. The cut across road is sort of like Alcoa Highway, right? Except picture Alcoa Highway, there may be parts of Alcoa Highway that are like this. 2 lanes, no middle turning lane, really no shoulder, cars whizzing back and forth, especially on the weekends because they're, visiting the lake. And one weekend, my daughter and I had a great time at the lake with my parents. We were driving back. You can kind of picture the situation with cars driving close together, not necessarily tailgating, but close enough together that it's pretty packed. And all of a sudden, we see something coming out of one of the farms on each side of this rural road, and it is a turkey. And this turkey just starts slowly walking out into the road. And so I have a decision to make, right? I'm driving a Toyota Corolla with my 15-year-old daughter. There's all this traffic. There's no shoulder. There's no turn lane. And so I can veer off the road, right? I can slam on my brakes. I can veer into oncoming traffic, or I can hit the turkey. So I've got decisions. I've got to make them fast. And really, all of the outcomes have some negative consequences. And I tell that story because I think it's a lot like the decision that's facing business owners right now as it relates to healthcare reform. You've got to make a decision. At this juncture, you've got to make it fast. Deciding not to decide really is deciding, and we'll talk about that. But no matter what you do, there's going to be some pain involved. And so let's start out with talking about the facts around healthcare reform. And again, we're just going to keep this high level. So brokers in the room, don't go nuts if I'm not giving every variable about all these regulations. But we do know that U.S. citizens will pay tax penalties in 2014 if they do not buy health insurance. I think everybody knows this. It's referred to as an individual mandate, one of the most controversial areas of health reform that was upheld by the Supreme Court last summer. And so that's when those of us in healthcare all realized, hey, we're really going to have to do this. The individual mandate really is going to be upheld. The other thing that's going on is that if those individuals don't buy health insurance, they're going to have to pay tax penalties. And right now, and I'm simplifying this because there are variables, but for most people, those tax penalties are going to be $95 or up to 1% of their income, whichever is greater for single folks, $2,085 or 2.5% of household income for families. So if they don't buy insurance, they're going to pay taxes. Why? The rationale for all of this is that, well, if they go to the hospital with appendicitis, they're going to get treated free, right? There's got to be ways to sort of fund all these uninsured people. So if you just take the example of a single person making $50,000, and this is just for easy math, their penalty would be $500. Now, the insurance that's bought on the marketplace will be subject to tax subsidies. And so people will, if they buy insurance on the exchange, they will be able to get tax credits. And we'll go into that a little bit more in just a minute. But this particular individual making $50,000 is not going to get a tax subsidy if they're a one-person household because they're not 400% of the federal poverty level. So that's where the tax subsidies kick in. You can use another example of a family of 4 making $65,000. That's not that uncommon in our area. Their penalty would be $1,600, and so we're looking at about $135 a month now. Do you think a family of 4 making $65,000 is under 400% of the federal poverty level? Where do y'all think that falls? Because it sounds like a pretty decent income, and it's what a lot of people make here. It's actually 300% of the federal poverty level. And so that family of 4 making $65,000, if they go buy insurance on this new marketplace that we're talking about, they actually will get tax subsidies. And so what we're driving at here is that families are going to have to look at what's cheaper, paying the penalty or buying the insurance with the tax subsidies. And those numbers are pretty close in a lot of cases, and so we'll build that up a little bit. Talked a little bit about the marketplace already. It used to be called the Health Insurance Exchange. Everybody's probably heard the term exchange, and I'll probably use that interchangeably. But the government has recently rebranded it as the Healthcare Marketplace. And I put the word new in quotes here because there are already online marketplaces, and this does promise to be online, that have been in the individual market for quite a while where individuals can buy insurance. And I know a lot about it because my now husband and I started a small business about 5 years ago. It was while I was at Summit, and we started a business on the side. And so not being married at the time, we bought his insurance on the individual market. And one of the things we've done in buying that is that we went to a website called eHealth Insurance. And you ought to check it out. Just, be careful what you put in, because if you just pretend you're going to buy insurance, your phone starts ringing off the hook. All these brokers are hooked up with it, and they'll call you. But you can go into eHealth Insurance, and you can put in your information, your age, you smoke, all of these different variables, and you do have to fill out a health questionnaire, which will be illegal starting next year. But what they'll come back with is a whole bunch of offerings for you. Now, the difference between eHealth Insurance and what's going to be offered on the exchange is that the exchange now endeavors to standardize the offering, and that's what's called the Essential Benefit Package. The Essential Benefit Package is really what all health insurers are now required to offer. And really what a lot of people don't realize is that what has happened out of this health insurance reform is that health insurance has become much more highly regulated than it ever was. Has anybody in here, and you don't have to raise your hand, but many people in the last 2 years have gotten actually a check back from their employer. It's called a medical loss ratio rebate. Does that sound familiar to anyone here? What happened with healthcare reform is that health insurers, under law, have their profits capped. So if a health insurer makes more than 15% profit, they have to get the money back to the insurers. And so that's a huge impact on health insurance. And some people have actually thought, that if they put health insurance out of business, it doesn't look like that's going to happen in this case. And so their profits have been capped, and they have to offer the essential benefit package on the exchange. So although the idea of being able to go buy health insurance is not brand new, it is somewhat standardized through the health insurance exchange to help individuals make good decisions. www.healthcare.gov is the exchange or the marketplace that the state of Tennessee will be using. You probably know that every state had to make two critical decisions, and one of them was whether to create their own health insurance exchange or to use the exchange that is established by the federal government. Our state made the decision to use the federal marketplace or exchange. And the rationale behind that decision was good. I think what Governor Haslam said is that really we don't know what all this is going to look like, and building this from scratch is going to be difficult. If you think about all of the things that have to come together to make the determinations on the exchange for what tax subsidies people are eligible for, et cetera, it becomes very difficult. So why build it? So most states actually made that choice. I do suggest that you go on the exchange. Go to healthcare.gov when you leave here, and just take a look at healthcare.gov, because it's actually a well-constructed website. It has very simple, plain English information on it, and not only for individuals, but there's also the opportunity for small business to buy health insurance on the exchange through the SHOP program. It's all a little funny about why you would really want to do that as a small business when you could just have your individual employees go to the exchange. That's something I really haven't figured out, and maybe brokers can comment on that. But just go take a look at that website when you leave here today, and we'll be publishing on our Strata website a list of different resources for you, and a link to that website will be on those resources. Okay, so here's the next fact. Originally, when the healthcare law was created and approved back in 2010, the notion was that you would get most citizens into insurance, and you'd get most employers either offering insurance or paying a tax penalty. right to fund insurance for those citizens who are getting it privately on the exchange. And so that all sounded great because obviously if you're spreading the risk of healthcare costs over a larger population, like the whole country practically, you're definitely going to be able to create better rates. And so what happened just a couple of months ago is that the government came out and said, you know what, we changed our mind. We're not going to charge employers for not offering health insurance. So the situation right now that we're facing come the first of next year is that all citizens are going to pay tax if they don't buy health insurance. They have the opportunity to buy it on the exchange and get the healthcare subsidies, the premium subsidies, but employers are not required to offer any health insurance, and even if they don't offer health insurance, they are not going to face a penalty. What were the penalties? The original penalties were $2,000 for all employers applying to employers with 50 full-time equivalents or more. And I know there are people in this room at all levels. I talked to some of you as you were coming in. We've got people in here with 30 employees and people in here with 75 or 100 employees. And so you're going to have to look at your own individual situation. But for employees over 50 FTEs, $2,000 per employee, but the first 30 employees are free. Okay, and we're going to work through a little example. State of Tennessee, I don't know how many of you remember this, but under Governor Bredesen, who was, I think, pretty anti-healthcare reform, came out and said, we've done an analysis for the state of Tennessee with our 40,000 employees, we could actually save $146 million if we just dropped our insurance and sent everybody to the exchange. Okay. So that was his sort of anti-healthcare message. And if you look at these numbers, what it comes out to is that they could pay the $2,000 fine for their 40,000 employees minus the first 30, and drop their health insurance and save $36.50 an employee. So if you back into this, what you see is that they were paying about $5,600 an employee for insurance. Now they'd be paying $2,000 a year for insurance. And so those numbers really work, and they work for most companies. There'll be a link to that article and that analysis in the resources page as well. So why is all this happening? This slide is from the Kaiser Foundation, and it talks about the average annual worker and employer contribution premiums for single coverage 1999 to 2012. And obviously you can see the trajectory because if you're a business owner and executive, you've experienced it. Back in 1999, the average overall cost was $2,100 a person, and $318 of that came from the employee, and $1,878 of it came from the employer. And so the situation we're in right now is that as an employer, if you offer insurance, on average, you're contributing $4,664 a year for employee health coverage. And the employee is on average contributing $951. So in this time period, this is tripled. Why is this? And I want to put on my healthcare hat and talk about some of the reasons why this is briefly, because I think there are some things that individuals and companies can do to help change the trajectory of these numbers, which is really what's got to happen. All of this reform is aimed at trying to change this trajectory because we can't afford it as a country and employers can't afford it. So let's just talk about a couple of things that people think are influencing this and what we're finding. First of all, the American lifestyle. It's really easy for us to just focus in on the American lifestyle and say, we're sedentary, we're more obese than we've ever been, we eat all sorts of processed foods, and that's driving up healthcare costs. And that is true by and large, but that's something we can do something about as individuals, and it's something that we can help create incentives for as employers. And you're going to find out one thing, I am a very pro-employer-based wellness program. I think it's just a really no-brainer for employers to offer this kind of services and create that kind of culture. So that's one major thing that is affecting healthcare costs, and it's something that we can control as individuals and as a company. Here's another example. I don't know if anybody here reads the Wall Street Journal regularly, but about 2 weeks ago in the Wall Street Journal, there was an interesting article about a fella who needed a hip replacement. Did anybody read that article in the Wall Street Journal? So this guy needs a hip replacement. He's about 55, 60 years old, and He is not covered by insurance because it's from a former sports injury, and it's a pre-existing condition, which, by the way, will also be illegal next year. Anybody want to just venture one guess? Please come on about what it would cost him when he priced this out to get a hip replacement. $200,000. Anybody else? The cost in the United States was $78,000 for him to get his hip replaced, and he was going to have to do this out of his own pocket. So what this guy did was he decided to price it internationally, and he ended up going to Belgium, and he got his hip replacement for $13,000. In the United States of America, that hip joint that he bought would have cost, just the joint, would have cost the patient $13,000. So there's something going on here, and if you really look into it, what you'll find is they do regulate the price of joints, what they can be charged to patients in Belgium. But he flew to Belgium, he got his hip replaced, and it cost him $13,000, and that included flying to Belgium. I hope he had a nice trip before us, beautiful country. But at the end of the day, that points to some problems that we have in our healthcare industry here, right? If you can actually make a joint cheap enough that it can be sold for $800, which is what was the cost of the joint in his surgery, and we're charging $13,000 for it, there's something really wrong going on. And so what we've got to do is be able to have technology become cheaper as it becomes better, like we have with our iPhones and our Kindles and our computers. I mean, gosh, I bought a computer recently for about $300. I can remember my dad in 1978 buying a calculator that did, plus, minus, times, and divided by, and I think he paid $200 in 1978. And now, calculators are throwaways, and you get a whole computer for that. Why hasn't that happened in healthcare? Well, some of it is just a lack of really motivation to innovate, but that's one of the reasons healthcare costs are high in the United States. Here's another issue to think about as you think about the cost of healthcare insurance and healthcare itself. A good example is breast cancer. Everybody knows about the Susan G. Komen Foundation and all of the work that she's done to raise awareness of breast cancer. And it's worked. People have really gotten a lot more scans. A lot of breast cancers about the size of my little pinky tip of my pinky nail hair are taken out, and women get radiation and chemo. But as a matter of fact, the death rate for breast cancer is virtually unchanged. And so what we're finding is that we're doing a lot more screens and a lot more chemo and a lot more radiation, but it's really not making a difference in the death rate at all. What it's doing is just raising costs for screening. And anybody in here, who's an advocate for that, that plugs people in. But it's just the truth. Just look at the studies. And so what they're starting to find now in science is that there are small cancerous lesions that come and go. And so if you get scanned every year and they find a little thing this big and chemo and irradiate you, that might have gone away anyway. So they're starting to do studies about wait and see. So that's just some food for thought about what's going on. And what makes it difficult is sort of the evolutionary nature and the fast pace of technology in healthcare, right? So what we can do things about many of those things, but there are also things that we need to lobby for. So let's use the example of our 100 FTE company just because the math is very simple. A 100 FTE company under the average would pay $466,400 in premiums on behalf of their employees, according to the math we just went through. I promise this is the most complicated slide I'm going to show you. It's from the NFIB, and you can go look it up, and I'm not going to walk you through it. But this is a decision tree that will help you as an employer decide whether or not you want to offer health insurance, right? Because that's the decision facing us. And if you decide not to decide and keep doing what you're doing, you have decided, by the way. So the National Federation of Independent Business, this is an advocacy group for small business, they put this graphic up on their websites. And what they have here is the starting point of, do you offer health insurance to your full-time employees and their dependents? If you don't, do one or more full-time employees qualify for a government subsidy, meaning is their income between 138 and 400% of the federal poverty limit? This is their family income, so there's this whole element of, do you know what their spouse makes, and how do you even know the answer to this question? I would postulate that you can't, and you need to assume you can't when you're making this decision. But if this is the case, then you're going to pay an annual penalty, and we've talked about how that annual penalty works. If none of your full-time employees qualify qualify for a government subsidy, you won't have a penalty. Now, here's the deal. There are estimates on the part of the Kaiser Foundation that about 50% of eligible Americans will be eligible for the subsidy. So really, I think what you have to assume, unless you're a firm of 2 lawyers with no admin support, that you're going to have at least one full-time employee whose family income falls into this. And if you have over 50 employees who are going to end up paying the fine if you do not offer health insurance. If you offer health insurance now, what you've got to do is, if you plan to continue, make sure that your health insurance is in compliance. And in compliance means that it doesn't cost employees more than 9.5% of their income. And it also means that it covers at least 60% of the annual value of this whole list of benefits that the government says have to be offered. If your coverage does not meet that, if it's unaffordable, because you've got an employee who makes enough that it's 10% of their income to get insurance instead of 9.5%, or it doesn't cover 60%, then you will also get the penalty. Now, this is the worst possible thing that could happen to you. So, what you don't want to do is offer insurance and get the penalty because one employee was 10% of their income, or you didn't cover 59% instead of 60%. So this is where you're going to have to work with your broker and your advisor, and they've been doing lots of work. And in fact, many of the insurance offerings have already started just offering the essential benefit plan. That's what we did at Summit Medical Group when I was working there. And again, if one or more full-time employee doesn't qualify for the subsidy, then there is no penalty. So in making this decision, if you are going to continue offering health insurance, stay in compliance. But here's the true numbers. If you are a company of 100 and you don't offer insurance this year, you will have 0 tax penalty and 0 health insurance premium. You just picked up $466,400. So here's the fact pattern. The individual mandate, the healthcare marketplace, no employer mandate. A strictly financial conclusion is that it definitely makes sense not to offer health insurance, right? If you were just working by the numbers, right? But here's the rub, and before I go to it, I'll stop. I know I gave a lot of detail. Are there questions? Yes?
I heard a similar presentation the other day, and the gentleman said that this $2,000, $3,000 penalty is going to last for about a year to 2 or 3 at max, because once the government gets the data about all the employers paying the $2,000 penalty, that penalty will shoot up way high because the whole gimmick is based on a spreadsheet. And if the numbers are not working right for the government, 2,000 read 10,000, read 20,000 per employer, per employee, before you blink your eyes.
Yeah. And I'm not going to politicize this because a lot of what's coming out is political, but there's no doubt we're going to pay more taxes, period. Everybody's going to pay more taxes, whether it's in the form of this tax or other taxes. The country's broke, we're going to pay more taxes.
So this is basically a 1-year window that we're looking at right now.
It is.
Until they get their spreadsheet in order.
Yeah, yeah. But hopefully, I mean, the point of some of this, and I know there's lots of skepticism, but is to create some consumer awareness and some market dynamics that actually change that cost curve, right? And there are some things that can happen to make that real. And so it's our best bet right now. If this doesn't work, and I will put on my crystal ball, political or not, we probably will end up like Europe with the payer system. This is the last try. Yes?
I had a quick question about your statistic on breast cancer.
Yeah.
Obviously, the fatality is, I mean, no one's immortal, right?
No.
Is quality of life longer? Do you know if the statistics show
No, it's
that?
worse. In fact, all of the side effects, et cetera, and the risks related to getting chemo and radiation and surgery make it worse. I have 2 friends who went through it last year. One of them had a nightmare.
So the death toll is still the same, or the
Slightly
death rate
better.
is still the same, but
Yeah, it's slightly
still dying
better.
just as fast.
Yeah. But it's what, it seemed like it made sense on the front end, and that's part of the problem with defining quality in healthcare, which we're going to talk about. But it seemed like a great idea on the front end, and just now we're realizing it probably wasn't, and we spent a bunch of money as a country. People have gone through a lot of misery to find that out. And so now science needs to evolve. But yeah, it's one of those cancer screens that you have to tread lightly. I just took that from Breaking Bad, didn't it?
In terms of the individual's responsibility to own health insurance, if I am 18 years old, am I that person? Do I have to, what is the minimum age for the government to define me as I'm responsible?
I think it's 18. Like I said, I didn't get into a lot of detail
So
here.
holy cow, there are millions of kids on college campuses who don't know anything about this.
That's right.
And they could get a bill in the mail from the government,
They won't get a bill. What happens is it'll be taken out of their tax return.
and if they don't file a tax return,
Then they won't get a bill. But yeah, there's lots of nuances like this. But yeah, there's lots of people who don't have health insurance now that are like kids on college campuses. There's also people like my hairdresser who drives a nicer car than I do, who chooses not to get health insurance but goes to Jamaica every year. I won't tell you who she is, but you know, there's a lot of people like that. And I've said it to her face. It's like, you need to get health insurance. You can afford health insurance. And so at the end of the day, there is a whole population of people out there who do hair, they clean houses, they work in all sorts of industries who choose not to afford health insurance, but take vacations, and you know they can get health insurance. The other thing about this law, and then we'll get out of the weeds, is that it requires employers to allow parents to keep their kids on insurance until they're 26, and so that does take some of that into account.
last quick question.
Yes.
The definition of an employer, is it only for-profit organizations, or does it include nonprofits?
It includes nonprofits.
Thank you.
If you were an employer. And I'm president of the board of a nonprofit. We're having to evaluate this question for ourselves. We've got 13 employees. Okay, so here's what we're going to talk about now, worker engagement. And I love this graphic. This is the continuum of worker engagement. And if you were here for Jill Green and Christine Bell last month, I know they talked a lot about this. But you've got your workers, high contribution, high satisfaction workers who are very engaged, all the way down to your low to medium contribution and satisfaction workers. And really, you know, we don't want to have these dissatisfied workers. They're distracted. They're in the hall talking about, look what they did to our health care again. It's just the truth. And so what I learned at Summit at Designing Health Benefits is, and I've dealt with it with all sorts of companies, from small practices all the way to 1,000 employees. Whenever you make a change in benefits, people get scared and they get afraid. And all of the changes that employers have had to make in benefits in the last few years are negative, right? Because of this rising costs that we're facing. And so very important as an employer, if you're going to keep benefits, get the most out of that. If you're going to keep benefits, try to at least track people to the best value in healthcare. And we're going to talk about that a little bit and how you can do that as an employer. But you can make the financial analysis, but you cannot ignore the impact on employee engagement if you just say, we're not going to offer health insurance anymore, right? And that's everybody's big fear. We know U.S. citizens equate a good job with good health care benefits. Did anybody listen to Halloran Hill this morning? He had the funniest email that he had gotten from a young person who was struggling with student loan debt, who could not get a good job with benefits and actually was contemplating suing his parents for negligence because they had a nice car and a TV and all that. So that's another topic that we won't go into. But the point is, you know, he said, I just can't get a good job. I can't get benefits. He didn't even know, you know, he can go get benefits actually in 6 months on the healthcare marketplace. So we know that the good jobs are the ones with good benefits. The good jobs used to be the ones with good pensions, right? What happened there? Pensions are gone, and it's all 401k, and it's horrible, and you have to make a contribution to it. A lot of pensions were bankrupt to companies, just like healthcare is bankrupt to companies now. And that's why coverage has been shrinking, and there's lots of ways that you can slice and dice this data, but according to the census and then the study that was in the Wall Street Journal, only in 2010, only about half of employers were offering healthcare insurance, and there were lots of ways they were avoiding doing that. So ostensibly, to your question, half the people are out there right now needing to buy some sort of health insurance. Recently, UPS cut its spousal benefits. That made national headlines, and so anytime you monkey with the insurance, it causes all sorts of problems, especially if you're a big, visible employer, and frankly, it's led people not to offer insurance at all. Yeah.
The question to that, they say if your spouse has coverage, then you'd have to go onto their policy.
That's right.
Well, what caused them to say, no, you can go back on your policy?
Yeah, exactly. It's a good question. The point he made was that the nuance about UPS was that they told people that if they had availability from their spouse, that they had to go on their own insurance, if it's 2 jobs? And I don't know the answer to that question. What do you do? The other thing that was a big factor in that was that it only applied to non-unionized employees, and most of their employees are unionized anyway. So now they have this 2-class system of people who, they get this one set of benefits if they're unionized and another if they don't, and spouses benefits. And so, it kind of talks to the complexity of this issue. But one thing we do know, this graph is from the IMS group, but it could be any of our employee satisfaction surveys, right? A lot of employers do it every year, and the question is always rate your benefits. And the insurance packages, like health and dental, are always at the top. People want to get their insurance. And we want to attract and retain the best people, right? That's the most important thing to us. We all need good people. And we hear that, you can't find good people. And even in places like Knoxville, where our unemployment is relatively low, there are still some occupations that are really in demand. So I put this up from Wanted Analytics, which is a firm that focuses on business analytics in the talent marketplace. This summer, Forbes named Knoxville as one of the fastest growing cities since the recession. There's been a Brookings Institute study recently that talked about Knoxville and only one other city being city with the best recovery from the recession. This is a good situation for Knoxville. And so you can see Knoxville on here, and what this slide shows is a 60-day period, year over year, the number of total job postings. And in Knoxville, in 2013, it was up 10% over 2018. So 2012. So people are starting to begin to hire. And then you can see what the occupations across this whole universe are of what's in demand. Registered nurses, web developers. We all want, healthcare and tech in our community, right, to keep it thriving. And so what we don't want when we're thinking about our benefits offering is for the registered nurse who's going to move somewhere in the South to go to Greenville rather than come to Knoxville because there's a hospital there with better benefits, right? And we don't want people to move because of that either. And we don't want the people who are trained, the bright young people who are coming out of our excellent university here to move away because they can get a better deal somewhere else, job-wise on many fronts. And so it's top of the mind that what we want to do when we're designing our benefits offering is foster employee engagement. There's going to be a link in the resources. I couldn't get this list just for Knoxville about what the most posted jobs are and what the change is, but what it did talk about was what the most in-demand certifications are. Most of them are healthcare and IT related, which makes a lot of sense for our community. So let's talk a little bit about benefits and tie it into wellness programs. One of the things that happened with healthcare reform that was a little fuzzy was that the government actually offered grants to some businesses who wanted to establish wellness programs, and they had several millions of dollars invested in those grants. And they did distribute those grants. In our state, one of the participants is Shelby County government. And so it helps employers to establish wellness programs. And this is something that you really can do yourself. And I think what will happen with a lot of the insurance products on the marketplace is that wellness will be baked into that as well. And so you need to think about, as an employer, what you want to design in versus what may be designed in what people are buying on the exchange anyway. So, for example, my husband and I have insurance on the individual market right now that has a wellness program baked in. And so, through my Fitbit, my steps are transmitted to a website from my insurer, and if I get a lot of steps, I can win a TV, that kind of thing. And so those kinds of things are going to be happening in the insurance offerings. But really, most employers have been offering wellness programs. This is from ADP. A lot of people know them as a payroll company. Just talking about for mid-sized employees that they do offer insurance programs almost half the time, and in large companies they offer wellness programs. The Great Places to Work Foundation talks about what those look like, financial incentives, fitness centers, including employees in fitness centers, subsidizing gym memberships, etc. These are things that companies that have high employee engagement have been doing to engage their employees in a culture of wellness. And I thought this was a great graphic, the symbiotic relationship between a healthy organization and healthy people. Wellness initiatives promote a healthy organization, which promotes healthy people, acceptance of health and change, a healthy organization, And I know that we really experienced this at Summit. We founded a wellness program during my tenure there, and not only did it help keep our healthcare costs down, but it was also a great employee engagement tool. People loved the things we did. Let's get together and do the boat race for Carm, and let's do the buddies walk for cancer and all of that. So people met people that they wouldn't have otherwise met. So I encourage you to think about wellness programs no matter what you do. You can find many studies like this, but this introduces the concept of presenteeism. If you feel good, you're going to do a better job at work. If you don't feel good, you're not going to be as engaged at work. You're going to be walking around talking about how you don't feel well, right? And so by most estimates, the indirect medical costs related to people not being well are much more than the direct medical costs. And so while most employers offer wellness programs on a strictly cost incentivized basis, I think it's going to be even more important if you choose not to offer insurance to continue to incentivize wellness and to take advantage of some of the resources that are out there to do that. So I'll stop a little bit and see if there are any questions about anything we've talked about with employee engagement. Yes.
Well, I know Jim would know this, but if you ask the doctors to sum how much it costs for whatever treatment or procedure they do, I would doubt that they have any idea.
No comment.
But you know what I'm saying? I mean,
I was there. I worked for Jim Gal for 5 years.
Yeah, and he posted it. That, I mean, that's, they would not think that was ethical, but everybody knew what it was. And, the old days, you used to have a high deductible. You knew you felt it.
Yeah, we're going to talk a little bit about healthcare in a minute. Any other questions? Yes.
I was just going to clarify one thing, that you may have not meant this, but it sounded like that healthcare.gov is the only place you could get insurance, and that's not the case. You can get it actually. It's the one that's only going to offer government plans, but you can get private plans that are government qualified on a private exchange. So there will be places you can get insurance other than.
I bet you're an insurance broker. Yeah, no comment? Yeah, there are lots of places that you can get insurance. We get ours at eHealth Insurance, right? My understanding, and correct me if I have this detail wrong, is that you're not going to get any government subsidies unless you buy your insurance on whatever exchange your state has chosen.
Not necessarily true.
Okay.
That's the pervasive thought, but as long as it's a government, it's in bronze, gold, silver, platinum plan, it's one of those plans qualified by the government, you can still get the subsidy.
That's good to know, and it's not what it says on healthcare.gov. So,
Right.
yeah.
Because they want you to get
Yeah.
it there.
Yeah.
So
Just so you know, eHealth Insurance, their site is down just for a moment, maybe temporarily, but just so you know, as they make changes, they say.
They're probably trying to figure out what to do with their feet, right? Yeah. How to see that people can get their tax subsidies, and maybe there's a way that can happen. But what the government's saying is that, and I would want to get to the end of the tax year and kind of not know I didn't get my tax subsidies. And so I think most people will probably use that, but definitely talk to your broker about these details, because they're the ones who are going to be able to really get down and dirty with you about that. So thinking again about the impact on the workforce, what we're going to want to do no matter what we do is have a positive impact on our workforce and minimize the negative impact. And obviously just dropping insurance in a vacuum could definitely cause you to have a negative impact on the workforce. So let's talk a little bit about healthcare. And I'm not going to talk about Summit. I'm going to talk about healthcare in general and my 28-year career in healthcare, working for lots of places, including Summit. But the healthcare industry overall for a long time has been really struggling to define quality. And that's one of the key problems with the healthcare industry. The difficulties are really baked into that example about the mammograms, right? We all think that getting your mammogram every year is high-quality healthcare. Well, it may or may not be high-quality healthcare. But there are some basics that are becoming a standard. So, for example, the healthcare industry, as it is evolving, has agreed that it's a good thing that if you present to the ER with chest pains and you get aspirin. And that's a best practice in chest pain care. That doesn't happen all the time, and the lack of consistency across healthcare is really one of the things that has made measuring quality difficult, not to mention defining what quality is. Another thing that's agreed upon is that it's good to screen people who are Medicare age for fall risk. They don't like it, but it's good to screen people with Medicare age for fall risk because it costs the country millions and millions of dollars that people fall down. So striving to define quality, that's really been going on since the 90s when Hillary Clinton took a run at this, and I was working in healthcare in Orlando at that time. But some of the basics, again, are becoming agreed upon, and there are some programs now where quality metrics are agreed upon. So the Institute for Health Improvement created a concept a few years ago called the triple aim. And the triple aim is really what most of us call business. How do we deliver our service in a way that our customers have a good experience of the service that we deliver? How do we do it in a way that is affordable? And how do we create results across our customer base, right? And so the way this is framed up with the triple aim is how did the patient experience care? So if you've been in the hospital recently, what's going to happen is that you're going to be asked to fill out a survey as you leave the hospital. But if you're in Knoxville, Tennessee, your hospitalist physician, if there was Summit, is going to give you a survey because they're going to get better reimbursement if you had a good experience of your care in the hospital, and so is the hospital. Why? Because if you experience your care better, you're more motivated to go back and get your care, right? And you're more motivated to be forthcoming when you get that care if you have a trust relationship with your healthcare providers, because I know we don't all go into the doctor and tell the truth. In terms of the health of a population, the concept of population health is to look at any group of people, and for you it would be your employees, right? And to see how well they receive what's defined as quality care. So very simple, if you look at a Medicare population, any group of Medicare seniors, what you want to look at is how many of those people got screened for fall risk. And if they have a fall risk, how did you, for that population, begin to address that? And then the per capita cost is important. That's what that does. The per capita cost is important because it plays heavily into this notion of accountable care. I don't know how many, I know the brokers in the room have heard about this, but there's a new concept that is really a paragraph in the healthcare law called accountable care that has really been caused an explosion of some real disruptive innovation in healthcare. And so the per capita cost is an important concept there. So I'm just going to really, really oversimplify accountable care, and I will qualify this by saying I was involved in starting the accountable care organization that is owned by Summit. It's one of the largest ones in the country. There's three things that happen in accountable care. First of all, every patient has a budget. And so if you think about this in terms of yourself, or I'll use myself. When I went on to eHealth Insurance and I filled out my health questionnaire, the rate that popped up on the screen was not exactly the rate that came up at the end of the questionnaire because of some things. And so there was a care budget there. There were some actuaries that said, no, we really think it's going to cost a little bit more to care for Jenny because, she's sort of fat. And so a little bit higher care budget was established for me because of the likelihood of what could happen to me. This happens in accountable care too, and it's happening with our Medicare population. And what would that care budget possibly be? Maybe about $5,600, right? Because we looked at those numbers earlier. The second thing that happens in accountable care is that we're going to agree on what constitutes quality for this population. And so we've talked a lot about that. And so what the job is of the accountable care organization, which can be your doctors and your hospitals, Walgreens has 2 accountable care organizations, there's some real interesting things going on there, is that we're going to agree on what defines quality. And if we meet that quality and we exceed the budget that's been established for that patient, we're going to split the savings with you 50-50. So if the budget for me is $5,600, and you meet all the quality metrics that apply to me, if I'm supposed to get my mammogram, my God, blah, 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 and you come in under $5,600 for my care, I'll split it with you, government, 50-50. And so there's been a big experience going on through new care model, or experiment going on through new care models that are emerging with these accountable care organizations. And they're government focused, but it's definitely emerging in the private market and on the private exchanges, which were brought up over here.
Is not the patient, that contrary to the patient, that doctors say, I won't do that, but I'll get split what I'm not doing?
No, it doesn't, because that, whatever that is going to be part of that doctor's quality metrics. And so that's one of the big things that differs from what we were trying to do in the 90s. I worked in an insurance market where that budget was established, and the organization I worked for got X dollars per member per month and per patient, and we didn't have to meet any quality metrics, and everybody knows all the horror stories of capitation. People denied care that was needed, and so outcomes were not improved in the long term. Hence, why you've got to define quality and agree that you have to walk through that quality door, and then you can share money. And that actually happened in this experiment that I'm going to talk about. There were accountable care organizations approved by the government, 32, that started last year in a risk environment where they could get upside risk if they did better than budget. They had some downside risk with the government if they did less than budget. They had to meet all these quality measures, and guess what? Every single one of those 32 organizations met those quality measures. They all did. And the quality measures aren't like every person has to get a mammogram. It's like a certain percentage of people need to get mammograms. One of the things that's used commonly is what's called the D5 for diabetics. There are 5 things that we know for sure that if diabetics get, they're going to be better than if they don't get them. It has to do with blood pressure, LDL, A1C, the blood sugar, are they a non-smoker, or are they using aspirin when they need it, the D5. Only about half of the diabetics in the country can get that care. And so that's the kind of thing that's being addressed through having to achieve these quality metrics before you can share savings. So what happened here is that these organizations, 32 of them, representing, let me get my number right here, 669,000 people, they met the quality metrics, whatever the threshold was for their population, and then 18 of them actually did create savings. And so it's working. It appears to be working. That care is being improved. People who are diabetic are getting the D5. People who need to be screened for fall risk are getting it. And then people who, and that is saving costs. And the cost savings of that were $87 million, and $33 million of it went back into the Medicare Trust Fund. And so think about that as an employer or as a citizen, because you don't want those taxes to go up and up and up. If some of these care models will work, and it's the government, so they might raise that tax anyway, but if they don't raise it there, they're going to raise it somewhere else. But the cost of healthcare itself could be impacted, and so these models are emerging in the commercial world. And the rest of the story, so that somebody doesn't bring it up, is that 9 of these people did drop out of the Pioneer ACO program. 2 of them completely dropped out, and 7 of those 9 went to a sort of easier program where they didn't have programs like this. Last but not least, let's just talk about some of the care models that are emerging and some of the trends in healthcare that I think are hopeful signs. I'm going to look for an article. Okay. So how many people have been to a Walgreens or a CVS walk-in clinic? Lots of people. You go in, you make an appointment online, you pay $69, you see the nurse practitioner, you pick up your prescription, and you go home. And it's very convenient and it's cheap. And that is innovation in healthcare, right? That's a heck of a lot better than what we had to do before those were in existence. Has anyone, and you don't have to raise your hand for this, but one of the other interesting innovations like this is a company called Lab Test Anytime. There's one in Turkey Creek. You can go to Lab Test Anytime, and you can buy your own lab tests. And so, for example, I think there's some people here who were involved with me in the Go Red for Women campaign. I've chaired that event a couple of times. And so I'm all about heart health. And what is heart health? Know your numbers and manage your numbers, right? And so if you have to go to the doctor every time and pay hundreds of dollars just to know your cholesterol and know your numbers, you may not do it. But you can go over here to Lab Test Anytime, and you can take your cholesterol test every month if you feel like it. And so that's great for consumers, and that's a great way for consumers to be able to own their health, know their numbers, and manage their numbers. iTriage. Lots of people in here probably have iPhones. I have an app on my phone called iTriage, and last week I scratched my eye. I have a little dog who sleeps in the bed with me, and she scratched my eye in the middle of the night, so I woke up like, oh, and I don't want to go to the doctor. You know, we are on the individual market. We do have a high deductible, so I went into iTriage, and I took a look at, what do I need to do about this eye scratch, and ended up going to the optometrist instead of the doctor. So that creates consumerism. We're thinking about what is the cheapest way to do this, and how can I find out how to treat myself if possible. Also, iTriage will direct you to doctors in the area, so healthcare people in the room, you might want to get your facilities listed on iTriage. Tons and tons of innovations in terms of home health monitoring devices. There are devices now, I'll give you an example. If a patient, maybe your mom or your grandma, has suffered from heart failure, and one of the things with heart failure is that if you gain weight suddenly overnight, you're retaining fluid, it's a sign that you're getting worse, and you might need some treatment that you could get to prevent you from having to go in the hospital. So there are scales you can buy now that will transmit the patient's weight every day through a computer, sort of like how my Fitbit will sync up with my computer or my smartphone, and it transmits it to the physician every day, and the physician can then call you or have their care coordinators call you, which is one of these innovations that are occurring, to talk to you about what's going on and get this all circumvented before you end up with a multi-$1,000 hospital stay, right? And so that's huge innovation. There's tons of this going on. Hospital Compare is a website from Health and Human Services. There's also a website called Physician Compare. You can actually go onto either one of these websites and you can see comparisons of physicians in terms of how they are ranking on those quality measures that we talked about. Because physicians and hospitals have been required to report on those for a long time now, and if they don't, they get fined. So that's brand new transparency too. How do you know if you're going to the best hospital? You just sort of go where people tell you, right? Well, as a consumer, you can now go on and compare hospitals and compare physicians in a manner that has never been possible in the past. And my favorite is Oscar. Maybe the brokers in the room have heard of Oscar. But Oscar is a health insurance company that's going to be offered on the marketplace in the state of New York. And Oscar was started by 3 tech entrepreneurs. One who, there are people who are involved in development of things like Instagram. You've heard of Instagram. These young tech guys. One of them, who has many employees, opened up his insurance bill and said, I can't understand this. This is ridiculous. The IT industry owes it to this country to do something more than use our talent to try to get people to click more ads. So let's try to do something good. So they started Oscar. And this is a Forbes article about Oscar, but the goal of Oscar is to redesign insurance to be geared toward the user experience, to get patients to seek out their insurance before they seek out their doctor. This is very, very different from what we're used to. But hey, it's innovative, it's new, right? What we've been doing hasn't been working that great, so let's try something else. So how is Oscar going to do this? Well, they're introducing elements like free telemedicine. If you buy Oscar on the exchange, you can actually get a free consult with the doctor on the phone, no copay. That's cheap. Free is cheap, right? Why? We talked about how these companies are going to have a chance to share savings, right? So Oscar is incentivized to get you to talk to someone on the phone before you run to the doctor's office or the emergency room or the urgent care or whatever you're going to do. So free telemedicine, free generic drugs, online price comparisons. Their plan is to pioneer a consumer experience, not a processor of claims, and their goal is to simplify guiding individuals through the complex health system in an integrated and safe way. So this is great. This is innovation that would not have happened without the Affordable Care Act, and it's people who are using a different viewpoint to try to do something different and hopefully create different results. Another thing that's happening is, anybody take Consumer Reports? Consumer Reports just put out a new magazine on health, and this is a whole section that says what works and what doesn't, what your doctor won't tell you. So again, this is enabling people to own their health. Why? They're going to be paying their own premiums. They're going to be paying more out of their pocket. You're going to be a lot more concerned. That's a good thing. So we've got new consumer focus, transparency, and innovation. So the fact pattern around the healthcare industry, I think, is hopeful. I think healthcare is evolving, and I hope that consumers will be more motivated to own their health. I think that healthcare is going to continue to define quality and meet the needs. And frankly, if the traditional healthcare industry doesn't do it, there's a lot of people stepping up to the plate to do something different. So with that, I will take any questions about the healthcare industry. Yes?
From a quality standpoint and determining that, how much does the electronic records play into that?
It plays a lot into it, and another part of the Healthcare Act was to incentivize physicians to install electronic medical records financially. And so that's happened. In fact, we finished our electronic medical record rollout while I was at Summit. The problem with electronic medical records is garbage in, garbage out. And so the biggest challenge with electronic medical records, and probably some of you have gone to your doctor and heard them complain about it, the data has to be put in a certain way for it to be trackable and to come out right. Doctors hate doing that. They hate typing on computers. So, and they hate doing it a way that's different from the way they've always done it too. Just like all of us, we have a routine in how we do our work. But there's tons of data that's being compiled through the electronic medical records, and it's a big part of what Oscar says that they're going to use to help improve the experience of care and to help guide people to the less expensive, more effective options. Any other questions? Okay. So here's Jenny's crystal ball. We've already talked about taxes. Obviously, taxes are going to be higher, whatever they decide to call them. And that's going to happen no matter what happens with health care. I do think that fewer employers are going to offer health care coverage. And I think that's because we saw this happen in the market with pensions, that there are options out there that are affordable. One of the resources that you'll have is a map. There's a website with a map on it, and it talks about the rates for each state. The Tennessee rates haven't been released yet, or I would talk about that. But each payer that's going to offer an offering on the exchange has to go through basically a rate filing process, and they have to publish what their rates are going to be for the various levels of plans. There's 4 levels of plans that people can buy on the exchange. But what it's looking like is, for the preliminary rates that have been released, is that for some of the more rich plans, they cost more. For some of the higher deductible plans, they cost less, right? I think employer creativity is going to be higher, because if you're not going to offer health insurance, you've got to think about how do we retain and attract the best and the brightest, and there are some ways that you can do that as an employer. Also, I think consumer health behaviors will be improved for all the reasons that we've talked about. I think there are more resources than have ever been available to us as consumers to own our health. I think we can learn about the things that are challenging us and what our risk factors are through all the resources out there. And I do think we're going to see some really interesting innovations in healthcare. And those are Jenny's predictions, if you're not necessarily representing Estrada, the Chamber of Commerce. So the question we always ask ourselves at Estrada is, what is your next move? Our goal is to create an opportunity for every business to succeed by helping you to know what you don't know, make informed decisions along with your advisors. So here's the sort of things that you can be up against. The first one is you're not currently offering coverage. And if you're not currently offering coverage, you've actually just picked up an advantage, right? Because now employees can go get health insurance, and that health insurance can be affordable for them. And so you can help them to understand what's available to them now, and in fact, you're required to do it. There's a notice that you have to put out as an employer by October 1st. So if you don't know about that, go on the Department of Labor website and get guidance on that. But you can talk to them about how coverage is available, about how there are tax incentives, and you can get them connected to the patient navigators. If you haven't heard about the navigators, the government has spent about $60 million contracting with not-for-profit organizations. There's 2 in the state of Tennessee, and these navigators are going to be available to help people sort through all this, individuals. I do suggest that you found and improve wellness initiatives for all of the reasons that I've talked about. And you need to prepare for the 2015 impact, especially if you have over 50 employees, right? So if you have over 50 employees, you're going to be subject to the penalty. Yes?
What are the 2 organizations?
Oh, I was afraid someone was going to ask me that. And you know what I did? I put a link on the resources to that so that you could look it up. One of them is the Primary Care Association, and one of them is something called SEED, S-E-E-D, and that stands for something, and they're both not-for-profits. But yeah, every state has one or more. Originally, they earmarked $50 million to do this, and actually added several more $1 million. Obviously, it's going to be challenging for people to sort through this. So again, if you have more than 50 employees, prepare for that 2015 impact. Am I going over time? Okay, all right, just making sure. And so in 2015, here's what it would look like for that 100-employee company. 0 health insurance premiums, and you have $140,000 tax penalty, give or take, depending on nuances, right? And so versus $466,400 in insurance premiums, so you would have a pickup in 2015 of $3,200. And that's pretty similar to Governor Bredeson's analysis. Now, is that penalty going to go through the roof? It might. If you're offering coverage, you can wait, see, and prepare. And this is sort of the default for a lot of organizations. I talked to a major employer here in town who just said everybody's waiting for somebody else to go first in terms of dropping their insurance. And so what a lot of employers are choosing to do that I know of in this region is to wait, see, and prepare, continuing to offer coverage. But the most important thing to do if you're going to offer coverage is work with an insurance broker and make sure that you are compliant. And I have a comment.
Well, I was told by an insurance broker that people are going to be allowed to renew, like October, November, December, for a whole another 12 months, kind of based on current rules, so they can combine themselves another year, if you will.
Yeah, I've heard that too. There is this whole thing that you need to talk to your broker about being grandfathered in as a plan. And I'm not going to get into it because that's why brokers are giving 7-hour seminars on this. But there are ways if you have not changed your coverage since the health care law was founded that you can do that and not offer the essential benefits package and not get the penalty. But again, that's something you got to work on with your specific advisors and your own exercise of how this impacts you. It's going to be a little bit too conservative. Did I answer that? Yeah. You do need to expect steady increases in cost in terms of employer-sponsored plans. There's the trajectory continues, and there's some theories that because a lot of employers weren't offering the essential benefit plan before, they're having to do that. It's going to cost employers and employees more. Found and improve your wellness incentives, and really make the most of your advantage, right? If you're using this as an attraction and retention tool, hey, a lot of employers out there have dropped their coverage. We're offering coverage. This makes us a much more attractive option for you. Just make sure it's cheaper than if they go out and buy it on the exchange. And you really need to do a thorough analysis of your long-term strategy in this regard and what it means for you as an employer in terms of retention. If you drop coverage in 2014, craft a positive message. Don't just drop coverage in a vacuum. So do the required notice that everybody has to do whether they drop or not, but you can put this in a positive light. Employees will have tax subsidies available to them. They will have more flexibility in choosing what coverage they do and don't want instead of just choosing from a limited offering. Their insurance is now portable. If they leave their job, they can take it with them without interruption. And so those are all some of the advantages that you can communicate to your employees about this. And don't just go spend all of the money that you pick up from this. Think about some other ways that you can become an attractive employer in this period of time when the penalties are what the penalties are. We know for 2014 that's 0. One of the things that you can look at is defined contribution plans, and I put up on the resources there's a national broker that just has a handbook out about that. Obviously, you're going to want to work with your own local people, but it talks about how you can create an allowance for employees to help them offset their cost on the exchange that's tax deductible for you as an employer, and still lets them get the tax subsidies as an employee, so everybody can come out a little bit better. You're still going to be paying the fine. And think about some out-of-the-box benefits. I just looked at Google and what their benefits are. They do things like legal assistance, daycare assistance, time off for new parents. I mean, are there ways that you can reinvest this money that you're going to be saving if you don't offer insurance to make yourself more attractive? And then, again, you'll see it on every slide, found and improve your wellness incentives. So with that, are there any final questions? Yes.
Again, the question, what does penalties affect was?
His question was, can I go over the penalties and talk about when the penalties take effect? For individuals and businesses. For individuals, yeah. For individuals, if you don't buy health insurance, the penalties take effect this year. And, next year, 2014, this upcoming year. And so if you haven't bought health insurance, when your taxes are settled, you're going to pay the government.
If you haven't purchased insurance when you settle your taxes, by the time you settle your taxes,
yeah, what's going to happen is the money that you're being fined by the government is going to come out of your tax return or be added to your tax bill. That make sense? And then for employers, what's going to happen is in 2015, what's planned is a $2,000 per employee penalty for employers over 15 employees. We have over 50 FTE.
And for local employees.
No penalty.
So, do you think that the companies are dropping, the companies choose to drop insuring their employees? If they will continue on with the wellness program, if they're not looking at their ROI and what they, what do you think?
I hope they will, because this is where the rubber meets the road about the ROI related to presenteeism and absenteeism and all that, right? Which I believe in. I just think if people feel better, they're going to be better workers. And the community that they spend the most time in is the community at work. And so very simple things can be done, like don't put junk food in vending machines. Don't give, I was called the food Nazi at Summit because we wouldn't serve desserts and sweet tea at meetings because there's motive and then there's opportunity, right? And so don't, make time for your employees to exercise. Pay for a gym membership. Just show that it's important to you. And so I think all of those things are important. Not only as an employer, you're going to get better performance, but it's just better for the nation, right? Because more of us as taxpayers. Yeah. No one ever believes that, well, I shouldn't say it, but there's much controversy about even the hard dollar ROI on wellness programs. It's a hard sell period. And so you either believe it or you don't, and I sound like an idealist, but I think you kind of be the change you want to see. And so we can make a difference by being healthy, and as employers, we have a unique position to create an environment where people can be healthy.
Do you have the element of adverse selection in here, and the young person says, I don't want to participate, and all of a sudden, I find out I've got some, ailment that's going to cost me a lot, and they get immediately back into the system?
Well, what's going to happen if that young person doesn't select is that they're going to pay the tax penalty, right? And so the idea is that there were a lot of people who didn't select, and then they have this condition, which they'll end up getting treatment for one way or the other, right? They'll go to the emergency room or whatever when that appendix ruptures, and then we all pay for it in higher healthcare costs. But the idea of the tax penalties is to minimize that adverse selection by getting as many people in. Yes.
CMS is going to control all this. I don't know if you're familiar with open enrollment for Medicare beneficiaries. It's going to be the same way. You're going to December the 15th October the 15th through December the 7th. Each year will be the time you can enroll for these individual policies. Now, it'll be broader this first year. I think it starts in October and it goes through March or April. But then each subsequent year, it'll be October through December. So if you get sick in June, no, you won't be able to just jump on, which is a good thing.
Yes.
And the tax penalties go up just like the employer penalties, right?
Yeah.
Is your presentation on that website? Is this PowerPoint that you did today, is it on that website?
No, it's not. There is a list of resources on the website, though.
Could you go back a few screens?
Of course.
The one that said offer coverage, ensure compliance, expect increased costs.
Oh, my crystal ball.
No, you passed it. So go down.
This one?
That's it. Could you leave it up there a second?
Of course. Any other questions? Yes.
Can you describe what an ACO looks like? How is it different than traditional patient-physician relationships?
Yeah, the accountable care organizations are primarily in the government space right now. They're emerging in the commercial space, but those are groups of physicians and or hospitals that come together to try to come in under that budget, right? Meet those quality measures and try to come in under that budget, and those are the organizations that will split the savings with the government. How does this require explanation? Any other questions? Okay, well, to close, I just want you to know I did run over the turkey. It was gross. Kind of our dinner. However, hopefully we've given you enough information here today that you know a little bit more about what you don't know and that you're able to ask the right questions to your advocate.
Many thanks September 9th, the SBDC here is going to be offering the only exchange that we know of in the Eastern region, which really is just across the hall from us. And they'll be here. That is now what the government calls the marketplace. So they'll be here on September 9th. You can register at www.tsbdc.org.
Is that the co-op that's coming?
Yes.
Shared version? Yeah.
Yes.
That's the co-op, yeah. One of the officers on the exchange, yeah.
Okay.
It's actually outside the exchange.
Yeah.
It's kosher.
The co-op will be here on September 9th to present their offerings and explain more on how the co-op works.
That would be me. I'll be outside and you can say that. Yes, I'll be here to talk about more about the co-op and the organization.
Oh, good. Oh, good. So, glad you're here, so you heard this one, and so,
I'm sorry, I didn't mean to mess you up. I just didn't want people to think healthcare.gov was coming.
no, healthcare.gov is not coming, so, again, thank you for coming. I think parking places are validated out front, and look forward to seeing you again. Thank you again so much. Thank you.
Thanks, Ted, you too.
Cookout. Yeah. Thanks, have some. Okay.
Very good speaker. That's a pretty good question. Yeah, that's what she said. A good bit for practice.
Are you using, like, yeah,
Well, you build momentum, but it takes a lot to get there. Yeah. Kevin,
I've been
More competition from the big guys who play on the side.
Well, I do organization. So like some people.
So, like, my